Welcome to AETCM, the Emergency Medicine channel. Shall I? Today I'll be presenting a case of 52-year-old female who presented with complaints of paresthesia and weakness of bilateral lower limb and upper limb. On 10-second assessment, patient was conscious, oriented and obeying commands. Primary survey, airway was patent, there was no secretion, gurgling or pooling of saliva. On breathing, patient was having air entry bilaterally equal with normal vesicular breath sounds and adequate chest raise. Patient was having a respiratory rate of 18 per minute with a saturation of 99% at room air. Circulation, patient had an heart rate of 84 per minute which was with regular rhythm and a BP of 140/100 mmHg. All peripheral pulses were felt. 2 IV cannulas were put at that time. Coming to the disability, patient had a GCS of 15 out of 15 and pupils were equal and reactive to the light. On examination of the power, patient was having 4/5 power on bilateral upper limb and 3/5 power on the bilateral lower limb with a poor hand grip. Exposure, patient was febrile and GRBS was 140 mg per deciliter. Coming to the adjuncts to the primary survey, ABG was done in view of the quadriparesis to know whether there was any acid-based derangement or
what
PCO2.
What acid-based derangement you want to rule out?
There can be any respiratory acidosis, hypokalemia, electrolyte
Metabolic alkalosis, hypokalemia. It is the most common cause for bilateral upper limb and lower limb weakness. Hyperkalemia also can produce weakness.
Hypokalemia.
Only hypokalemia.
No. Can produce.
Both can produce. Both hypokalemia and hyperkalemia can produce paralysis. How do hypokalemia produce paralysis? What is that mechanism? What is that condition called as?
Hypokalemic periodic paralysis can be.
Sudden weakness of all the four limbs are seen in hypokalemic periodic paralysis. What is the mechanism? You only read about GB syndrome. That is the problem. What is the mechanism of that?
In GBS syndrome?
No, I am not asking GBS. I am asking hypokalemic periodic paralysis. That is one of the common conditions.
Potassium influx is the mechanism of mainly the resting membrane potential.
Okay.
So if there is hypokalemia, is there?
That I understood. Hypokalemia can produce the weakness, but how do hypokalemia happens in this patient? Hypokalemic periodic paralysis. Shift. A sudden shift of potassium because of what is the trigger in that most of the patients? Trigger. Protein.
Yes.
It is not protein.
Insulin intake.
What food?
High carbohydrate rich.
So normally person with high carbohydrate diet, patient develops sudden weakness of all four limbs. Okay, what are the other condition patient can have hypokalemic paralysis other than periodic paralysis?
Infections.
Infection will not produce hypokalemic paralysis. Tell one more condition which can produce hypokalemic paralysis. That is different. That is because of vomiting can produce. Okay, that can happen. But what is the other common condition which will? At all mild hypokalemia. One condition will produce high potassium deficiency with hypertension, weakness. What is that condition? Primary hyperaldosteronism, Conn syndrome. Okay. So hypokalemia is one of the important conditions we can get paralytic presentation. Okay. So that's why we are checking the ABG. Not other electrolytes like sodium can produce bilateral weakness. Produces generalized weakness, but there is no muscle weakness. Magnesium.
Hypophosphatemia can also.
Hypophosphatemia can present with this one. What is a common condition where hypophosphatemia occurs? Common presentation of hypophosphatemia.
Hyperventilation.
Severe diarrhea. Patient who is having severe diarrhea, after some days he can develop hypophosphatemia. Okay.
On ABG, patient had a pH of 7.4 with a PCO2 of 41, potassium was 4.1, sodium 143 and bicarbonate was 25.
Okay. Sodium 143, will it tell you something, or it's just a investigation like other investigation? Is it important in emergency medicine department or not? Hypernatremia. What it indicates?
Dehydration.
Dehydration is the most common condition where you get hypernatremia. Sometimes it can be lab error also. Okay.
Coming to the secondary survey, in sample history, patient was apparently normal until 29 December. Then patient had complaints of paresthesia of both lower limbs since 29 December evening. Paresthesia was mostly in the calf muscles, and within the few hours she had similar complaints progressing to the both hands.
Okay.
Then it gradually progressed to weakness of the bilateral lower limb within 3 to 4 hours. She found difficulty in getting up from the squatting position and from the toilet seat, and had difficulty in climbing the stairs of the house. Next day, patient had lower limb weakness, which progressed such that she had one episode of sudden buckling of both knees and fell on the ground, and she had difficulty on getting up from the ground. Patient then started to have weakness of bilateral upper limb in form of, like, she had difficulty in holding cups while having tea, and buttoning and unbuttoning the dress. There was no history of any cranial involvement or loss of sensation or any
Cranial
speech.
nerve involvement, you mean to say cranial nerve
Nerve
involvement.
involvement. No history of any loss of sensation in the bilateral lower limb or upper limb. There was no speech disturbances or slurring of speech in the patient. A patient had a past history. Patient had an history of fever 1 week back, which was associated with cough. And coming to the other system examination, on respiratory system, air entry was bilaterally equal with normal vesicular breath sounds. Per abdomen, it was soft and non-tender.
Here, what else you want to document other than routine examination of respiratory system?
Single breath
Single
count.
breath count is very important. Did you?
Yes,
Okay.
it was 35
Okay.
initially. Then coming to the CNS, per patient had a 4/5 in bilateral upper limb and 3/5 in bilateral lower limb. Deep tendon reflexes were biceps and triceps supinator, it was bilaterally absent. Then on sensory examination, patient had equal sensation in bilateral upper limb and lower limb. Cerebellar signs were negative. Gait could not be elicited because patient was not able to stand without support. Coming to the CVS, S1, S2 was hurt, and patient was having a normal BP and pulse rate was normal.
That alone is not sufficient. That is MBBS case sheet. In a suspected case of GBS, what else you monitor?
Fluctuating BPs.
What? Reflex she has seen, no? She has seen. I'm asking CVS.
Fluctuating
Fluctuating?
BP can be there in patient. Autonomic dysfunction can be there. So
Autonomic dysfunction can. How do you diagnose autonomic dysfunction in a case like this? You cannot make the patient stand. What else you can observe in autonomic dysfunction? What is the most important finding you see in autonomic dysfunction of patient on monitor?
fluctuating BPs.
Fluctuating BP is okay, but you need to monitor for some time. What is the first evidence of autonomic dysfunction in heart rate?
Sweat, heart rate, bradycardia, and tachycardia can be there.
It has to occur now, then only you will understand. What happens when you take a deep inspiration? What happens to heart rate? Inspiration increases the heart rate. Inspiration increases the heart rate. Expiration decreases the heart rate. That is called as? What is that phenomenon called as? It's a normal thing you see every day. It is sinus arrhythmia. It is a common arrhythmia. It is called as sinus arrhythmia. That will be absent in autonomic dysfunction. So one of the earliest sign of any autonomic dysfunction is heart rate will be fixed. Okay, if you see the monitor, it will be continuously same whether the patient takes deep inspiration, expiration. If we can monitor, that is one of the best tool to monitor autonomic dysfunction. And if the patient is able to stand up, then you can see postural hypotension. That will be the earliest finding. Then, like you told, tachycardia can be there, bradycardia can be there. Sometimes hypotension can be there, hypertension can be there. But all because of the dysregulation of autonomic function. Okay, so every type of arrhythmia you can see in all types of arrhythmias you can see in this type of patients. So you have to monitor everything. When you are seeing the patient, you have to see the single breath count. You have to document. You have to see the what is the heart rate, whether heart rate in inspiration, expiration is normal. If possible, patient we have to document a standing BP and postural hypertension. Okay.
Then patient was evaluated for the nerve conduction study for telling the prognosis. So it showed an evidence for motor polyneuropathy with conduction block affecting the bilateral upper limb and the lower limb.
Okay.
It was done for the peroneal, tibial nerve, femoral and the ulnar nerve.
Okay. It is symmetrical or asymmetrical? That is a very important.
It was symmetrical.
Symmetrical means mostly it is GPS. Asymmetrical, there are a lot of other conditions, differential diagnosis can come.
Then CSF study was done. In that proteins was 38, total count was 2. There was no atypical cells and glucose was
What is the normal CSF cell count?
Cell count more than
Normal. More than 4 means 20 is normal. 30 is normal. Huh? What is the normal count? Less than 5. Less than 5 is normal. Okay. More than 4 can be 5, 6, 7, 8 like that. So it has to be, suppose you want to tell 4, it has to be less than 4. Okay. So cells are normal.
normal. Total count was only 2.
Oh, okay. Protein?
Protein was 38 and
It is elevated.
yeah.
Okay.
Protein is normal.
Oh.
Glucose was elevated. It was 66.
66. Okay. Albuminocytological dissociation. Where will you get this? Albuminocytological dissociation. Where all you get? Where will you get it? That is only one condition. That is the most important for a MBBS doctor. But for you?
Hemorrhage.
Hemorrhage cells will be high. Cells will be high. Protein also will be high. One is GBS. Most important, most common is GBS. Proteins are elevated because of the inflammation. Cells are not elevated because there is no infection. What are the other conditions where you get elevated albumin? Then normal. What is Freund syndrome? You might have read about that, Freund syndrome. What is that? Freund syndrome. Obstruction to CSF due to some tumor. So below that, if you do a CSF, then the protein will be elevated. Then any coma you get elevated protein, metabolic coma, hyperthyroidism. Mixed edema coma also you can get same thing.
Transverse
myelitis you can get elevated protein, cells will not be elevated. Multiple myeloma, multiple sclerosis also you can get. Okay, so there are so many conditions which can elevate protein that simply tell you that there is an inflammatory process going on in the CSF than an infection. Okay, here it is only inflammation, there is no infection. Okay.
Then patient was started on IVIG. 400 milligram per kg per day is the dose of IVIG given. So patient was given 150 grams over 5 days of duration.
Okay.
And then patient started to improve the weakness in bilateral upper limb and lower limb. Within 1.5 weeks, patient was ambulatory, and then patient was started on physical rehabilitation.
Okay. Role of steroids?
No, steroids are contraindicated.
There is no role for steroid in at least in multiple myeloma. Okay. Sorry, at least in GBS. Okay. So what is your clinical diagnosis here? Guillain-Barré syndrome. What type of neuropathy it is?
Myelopathy, acute inflammatory demyelinating polyneuropathy.
Okay. Myelopathy is involved? Yes or no? Myelopathy is there.
Some variant can have a
there is a variant. Normal GBS is your spinal cord is not involved. Only peripheral nerves are involved. Some variants you can have spinal cord involvement. Some cases you can have brainstem involvement. Okay. Suppose this patient is having cranial nerve involvement. What is that variant called as?
Miller-Fisher involvement.
That mostly will be descending type of weakness. Patient starts weakness from the top and it descends down.
Ophthalmoplegia will be there. Ataxia, areflexia can be there.
So what are the differential diagnoses for that type of GBS? Miller fissure is that exactly that condition is Miller fissure. Differential diagnosis for that descending weakness. Where will you get? Huh?
Botulinum toxin.
What is that?
Botulinum toxin can be
Botulism
the
is one differential diagnosis.
presenting.
Then
Myasthenia gravis
myasthenia gravis can be there, but that weakness pattern is slightly different. The weakness starts like
ophthalmic variant of myasthenia gravis.
ophthalmic variant of
Variant of
myasthenia,
myasthenia gravis.
but there is no weakness. What else? Tick paralysis.
Tick
Tick
paralysis
paralysis I got similar feature. That will also have descending type of weakness. Ascending type of weakness, where else? Like areflexic quadriplegia, what all conditions you can get. This tick paralysis and what is that? What else you told? Tick paralysis and botulism.
Botulism.
They are already there. Other causes for generalized muscle weakness.
Transverse myelitis.
Transverse myelitis normally will have only paraplegia.
Myositis.
Polymyositis. Polymyositis, what will be the clinical feature?
There will be muscle weakness
Along with
along with a
polymyositis. What will be the important clinical finding of polymyositis? Muscle
pain will be more and weakness
pain
will
and
be
tenderness is more than the weakness. Okay, so severe pain will be there, and what will happen to the CK?
elevation will be
Creatine
there.
kinase will be elevated. Okay. Now, what are the other associated clinical features of GB syndrome? Muscle weakness is very important because it's a polyneuropathy. Okay. Post-infective demyelinating polyneuropathy. Okay. What are the other different other associated features of?
There will be a reflexia.
Okay. Reflexia is part of polyneuropathy. Huh? Respiratory paralysis can be there. Okay, diaphragmatic weakness and patient will develop breathing difficulty. We'll have to mechanically ventilate the patient. Okay, then heart, you already discussed.
Heart, tachycardia,
bradycardia, hypertension, all can be there. Okay, how do you manage that condition? How do you manage? If you have patient is having high BP, suddenly fluctuating BP, tachycardia is there, what is the drug of choice?
Propan.
Don't.
Labetalol can be given.
Alpha block. Labetalol is the treatment of choice. So that has to be like sometimes you will have to give. If it is only hypotension, then dopamine will be the treatment of choice. If it is hypertension, tachycardia, your labetalol can be there. Okay. Any like transverse myelitis, can you get all these things? This autonomic dysfunction. Yes or no?
Yes.
Where lesion will be where?
Sympathetic tract, thorax.
Thorax. Okay. So thorax, if you get a lesion, then you can get autonomic dysfunction there also. Okay. So autonomic dysfunction can be there in many patients with spinal cord injury, spinal cord involvement, all these things. Okay. Multiple sclerosis, how do it differ from your this condition? They also come with a similar type of presentation. Multiple sclerosis. What is multiple sclerosis?
It will be patchy. Weakness will be patchy.
Weakness will be patchy. Different areas, different time. If the patient is having weakness, different areas, different time, and you can get even sensory involvement. Okay. So that is a difference between multiple sclerosis and GB syndrome. Is bladder is involved in GB syndrome?
No.
It is not involved. Okay. Now, what is the difference between axonopathy and demyelinating neuropathy?
In demyelinating neuropathy, there will be conduction blocks will be there. But in axonopathy, the amplitude of the conduction, there is no conduction block as such.
Understood. But how do it differ in prognosis of the patient?
Axonopathy, poor prognosis will be there.
Because demyelination, after sometimes it can grow and become normal after some time. Whereas axonopathy, the prognosis is very poor. Patient may not improve with your treatment. Okay. So that is a difference between axonopathy and this one. What are the variants of GBS? No need to tell the name. You tell me what are when you suspect a variant.
When there is sensory involvement.
When there is sensory involvement, you have to suspect a variant. Then asymmetrical weakness, you have to suspect variant. Then cranial nerve involvement. Ophthalmoplegia is a cranial nerve involvement. cranial nerve involvement also you have to suspect. Okay, so this so if it is associated with other involvement of other areas of brain, you have to always suspect a variant of GBS. Okay, what is the cause for this?
A post-viral infection, GBS can come. Patient
Only
had
infections can produce.
no in your older days, rabies vaccine
Okay,
used
any
to
vaccine
cause.
can human vaccines can produce this type of antibody mediated problem. Nowadays it is not there. Now it is mainly because of viral infections. Okay, anything else?
Lymphoma cases can be.
Okay, what that is it same as GBS or it's slightly different? GBS is a post-infectious inflammatory polyneuropathy.
Polyneuropathy.
Other one is an antibody-mediated polyneuropathy.
Polyneuropathy.
Maybe the mechanism is same, treatment is same, but if you don't treat the primary cause, again patient can develop the problem. Okay, so antibody-mediated destruction of your myelin sheet. Okay, anything else you want to add? So treatment is
IVIG.
IVIG and
Plasmapheresis can be
plasmapheresis
given.
can be done.
Usually
Then
2 doses are given.
Then one more important thing is that what is that?
Physiotherapy.
Huh? Physical. Okay, physiotherapy is very very important because if you don't try physiotherapy, after sometimes patient will become very weak and muscles weakness can occur. Patient may not be able to walk after some time. Anything else you want to add? Nothing. Okay. Thank you.